Good evening, everybody, and welcome to the uh, HCP Forum and Kolkata Anesthesia Academy webinar series. And I think we are on the 6th of that. And essentially, it started off as the postgraduate teaching program for the trainees doing DNB anesthesia at Apollo Gleneagles hospitals. And as we realized, their friends started coming over, and then we thought we'll make it for everybody, all of them who would be interested in coming through. And at the outset, a huge thank you to Dr. Jayati and her team at the HCP Forum. It is because of their efforts that this has been gaining grounds. I won't say that it has been hugely successful or whatever it is, but it is definitely picking up grounds. I can already see around 50 people who have joined in. So without further ado, what we will do is we will take up two topics. One will be the basics of ECG and the role of ECG in perioperative monitoring. And that will be taken up by Dr. Gaurav Moitro. Dr. Gaurav Moitro is well known in the anesthesia circuit in Kolkata, Eastern India, and as well as in India. He's been a senior consultant at the Department of Anesthesiology at Apollo Gleneagles Hospitals for a long, long time. I have known him for even longer time, since my days in college. Gaurav Moitro is an alumnus of Medical College, Kolkata. And subsequently, he went to Bombay and did his MD from there. And his areas of interest have initially was with cardiac anesthesia. And like me, he also started getting interested in the general anesthetics. And he's a integral member of the anesthesia team. He also happens to be the president of the state chapter of the West Bengal chapter of the Indian Association of Cardiothoracic Anesthesia. He's been an executive member of the Indian Society of Anesthesiologists of the West Bengal State Branch, as well as the executive member of the West Bengal chapter of the Indian Society for the Study of Pain. Anyway, without further ado, I would ask Gaurav to take stage, and I would request all of you to please put in your questions at the chat box, and at the end of the session we will take up the questions from the chat box. I think that is an easier way for us to function rather than have people randomly speaking. We find this is a much easier way. Dr. Jayati at the back end will be managing. You don't get to see her, but she does all the work behind at the back. And so please put in your questions at the chat box, and we will try and interact with you at the end of each talk. So first, Dr. Gaurav will take up the topic on ECG, and later I will come in, and you will have to bear up with me at the end about evaluation of cardiac risk for patients coming in for non-cardiac surgery. So over to you, Gaurav. All the best, and please take over the stage.
Thank you, Saikat, for your very kind introduction of myself. And I must say that you've been a great inspiration in all my academic endeavors. So thank you very much. Good evening, everyone. So my topic for presentation today is basics of ECG for perioperative monitoring. I would rather like to share my screen. So first we'll start with the components of the ECG. So the P wave. P wave is the atrial depolarization wave, and the duration is 0.08 to 0.1 second. The QRS complex is due to the ventricular depolarization, and the duration is 0.06 to 0.1 second. The T wave represents the ventricular repolarization, duration of which is 0.1 to 0.2 seconds. The PR interval starts from the start of the P wave to the start of the QRS, and the duration is 0.12 to 0.2 seconds. The QT starts from the start of the Q to the end of the T, duration 0.4 to 0.44 seconds. The RR interval is the interval between the two consecutive RR of the QRS complexes, and the duration is 0.6 to 1.2 seconds. The J point is the junction of the QRS complex segment, and the ST segment starts at the J point and ends at the start of the T wave. Therefore, it is a junction of the ventricular depolarization and the ventricular repolarization. So this shows a normal ECG with PQRS T waves. Here we can see the small square, and you have to know that the length of the small square is 1 millimeter and the duration is 0.04 second. And large square, the width of which comprises of 5 small squares, the duration will be 0.04 into 5, that is 0.2 seconds. So this is a magnified view of the PQRST. This is the PR interval. This is the J point, so it's a junction of the QRS and the ST segment. And the ST segment starts at the J point and ends at the start of the T wave. These are the PR intervals, RR intervals, and the QT intervals is already discussed. And now we're coming to the conduction of the cardiac conduction. The starts at the SA node, and after activating both the atria, it comes to the AV node, from where the bundle of phase arises, and then it divides into the right and the left bundles, and then through the Purkinje fibers, it activates the ventricular myocardium. So the PR interval actually represents the time between the depolarization of the atria to the depolarization of the ventricle. This whole time represents the PR interval. So how do we go about with the ECG? How do we read it? So the first step is to see the rhythm, then the rate, then the conduction, then identifying the heart axis, and then the morphologies of the P wave, the QRS complex, and the ST segments. And if you have a previous ECG, you can compare the current ECG with the previous one, and then you conclude the ECG. So how do we find the rhythm? First, you have to know whether it's a sinus rhythm. For that, every QRS has to be preceded by a normal P wave, and the rhythm should be regular when the RR intervals are equal. So once you have confirmed the rhythm, you then go to the rate. You have to count the number of the large squares between the RR interval, and then 300 is divided by the number of large squares between the RR interval to find out the rate. The conduction is interpreted by the durations of the PR, the QRS, and the QT. The axis, the normal axis of the heart is from the -30 to +90 degrees, and you calculate it by taking into account two perpendicular leads. One is the lead 1 and other is the lead AVF. The lead 1 is from 0 to 180 degree, and the AVF is from 90 to -90 degree. Now, what you need to see is that which way the predominant deflection on the ECG is, whether it is positive or whether it is negative. If the predominant deflection is positive on lead 1, also it is positive on lead AVF, that means the resulting vector will be in this quadrant, and therefore it will be a normal axis. Now, if the lead 1 is positive and the AVF is negative, then of course the vector will be in this quadrant, which signifies a left axis deviation. And in case when the AVF will be positive and lead 1 will be negative, it will be a right axis deviation. So this way we can find out the axis of the heart. The next step is to see the morphology. So the P wave morphology is seen best in lead 2. Here it should be upright, and in V1 it is biphasic. So you have to note any kind of change in the morphology, whether the P wave is hidden, whether it is retrograde, whether it is peaked. Peak P wave you find in right atrial enlargement like P pulmonale, and in left atrial enlargement you can get notch P wave, that is P mitral. The QRS you note for the QRS duration, the RS ratio, and the morphology. And the ST segment, you have to see the whether it's isoelectric, whether it's elevated, or whether it's depressed. Then if you have a previous ECG, you compare it to find out if there is a new ECG change, and then you conclude the ECG like, for example, this ECG shows shows a sinus tachycardia with a ST elevation, and which may be due to a myocardial infarction. This is how you conclude an ECG. Now coming to the causes of the axis deviation. Now left axis deviation is due to the inferior wall myocardial infarction. Why it happens? Because the QRS vector will be deviated from the area of the necrosis upward and towards the left side. Therefore, in inferior wall MI, we get a left axis deviation. Other causes are left ventricular hypertrophy and left anterior hemiblock. Right axis deviation we get in case of anterior wall myocardial infarction, where the QRS vector will be deviated from the area of the necrosis inferiorly and to the right, and also in case of right ventricular hypertrophy and left posterior hemiblock. So let me explain this. Coming back to the axis, if you draw the heart on this will be the inferior surface of the heart, here will be the apex, and this will be the anterolateral part of the heart. So if there's an inferior infarct, the axis will move away from this area towards this area. Therefore, in inferior infarct, you will have a left axis deviation. Similarly, in anterior infarct, the axis will now move away from that area of necrosis rightward. So you will have a right axis deviation. Now, next, obviously, in case of left ventricular hypertrophy, the axis will be deviated to that side, and in right ventricular hypertrophy, the axis will be deviated to this side. Now, in case of left anterior and posterior hemiblock, see the left fascicle, left bundle, when it comes, it divides into two fascicles, the left anterior and the left posterior. The left anterior comes down inferiorly and towards the right, and left posterior goes posteriorly and towards the left. So when the left anterior fascicle is blocked, the impulse will go through the posterior fascicle superiorly and towards the left side, and therefore there will be a left axis deviation. And when there is left posterior hemiblock, the impulse will come through the left anterior fascicle inferiorly and towards the right, and therefore there will be a right axis deviation. So that explains why we get this left and right axis deviation in these conditions. Now, something to talk about the genesis of the QRS. Now, for a ventricular depolarization to occur, the initial small vector is always from the left to the right through the interventricular septum. And this will be followed by a larger vector from the right to the left side through the free wall of the myocardium. So this is the normal physiology what happens. Now, what effect it will have on the left oriented leads and the right oriented leads? Now, for the left oriented leads, when the vector is going from the left to right, that means it is going away from that lead. So there will be a negative deflection in AVL, V5 and V6. And since the vector is a small vector, therefore it will manifest as a small Q wave, a small negative deflection. And then the larger vector will be from the right to the left. That means it is coming towards the left-sided leads. And since it is a larger vector, it will be represented by a large R wave, positive deflection and large R. So in all left-sided leads, normally we get a QR pattern. For the right-sided leads like V1 and V2, what we get is a RS pattern. Why? Because again, it is firstly the impulse comes from the left towards the right. That means it is towards the right-sided leads, but the vector is small, therefore it is a small r. And then again it goes away from the right-sided leads towards the left-sided leads. Therefore, there will be a negative deflection, and since the vector is large, it will be a greater deflection. So it will be a RS pattern. So for all left-sided leads, there will be a QR pattern, and for all right-sided leads, it will be a RS pattern. Now coming to the criteria of ventricular hypertrophy. Criteria for left ventricular hypertrophy is R wave in AVL greater than 11 millimeter. And this is the modified Cornell criteria. The other criteria is the summation of S wave in V1 and the R wave in either V5 or V6. If it is greater than 35 millimeter, then it again satisfies the criteria of left ventricular hypertrophy. And this is the Sotelo-Leon criteria. Now the right ventricular hypertrophy. Here the RS ratio in V1 should be greater than 1. But for that, you have to eliminate other causes where this can be greater than 1, like in posterior wall myocardial infarction and in right bundle branch block. So in the absence of posterior wall MI and RBB, a RS ratio greater than 1 in V1 will signify right ventricular hypertrophy. And the second condition is when the R wave in V1 is greater than 7 millimeters. Now coming to the intraventricular conduction defects. Now RBBB, what will happen? It will have a RSR dash in V1, V2. Why RSR dash? Because since the left bundle is conducting normally, so I already told that in the right-sided lead there will be an RS pattern. So this part is normal. Now because the right ventricle depolarization is getting delayed than the left ventricle, this R dash will occur. So R dash is because of the delayed RV depolarization, and the QRS will be more than 0.12 seconds in case of complete RBEB. If it's incomplete RBEB, the duration will be from 0.11 to 0.12 seconds. In LBEB, we get an M pattern in V5, V6 with disappearance of the Q wave. I already told you that in left-sided lead, presence of Q wave is normal. So when there will be LBB, the first thing is there will be disappearance of the Q wave, and this M pattern is because there will be sequential depolarization of the ventricle, because here now the right ventricle will be first depolarized, then the left ventricle, and because of the sequential depolarization, there will be two peaks and a M pattern. Again, the QRS will be more than 0.12 incomplete, and in incomplete it will be between 0.11 and 0.12 seconds. Now, left anterior hemiblock, I explained why there should be a left axis deviation, and since the impulse is going through the posterior fascicle towards the left side, obviously then there will be a tall R wave in the lateral leads, and since it's going away from the inferior leads, there will be deep S wave in the inferior leads. In left posterior hemiblock, again, I've explained why there is right axis deviation. The opposite will occur, the deep S wave in lateral leads and tall R in the inferior leads, because now the impulse through the anterior fascicle is going towards the inferior leads. Now this is an ECG of a 45-year-old woman who is asymptomatic. So what are the steps of reading an ECG? First, I told that you have to understand the rhythm. So here, first we'll see whether it's a sinus rhythm or not. So in all the, before the QRS, there are P waves. So all the QRS are preceded by a P wave. That means, and this P wave is a normal P wave. I don't find any abnormality in this P wave, because see, lead 2, it is upright, V1, it is biphasic, and the RR intervals are regular. So it's a normal sinus rhythm, and all the PQRS morphology are normal, the PR interval are normal. So this is a case of a normal ECG with a heart rate of 60, because if you count 1, 2, 3, 4, 5, there are 5 large squares between the RR. So 300 by 5 is 60. So with a heart rate of 60, it's a sinus rhythm and a normal ECG. From now on, I'll be only pointing out the valid points of the diagnostic points on the ECG, and I'll not go through the whole ECG. So what we find in this ECG, which is most significant, see the PR interval is prolonged. In every lead, the PR interval is prolonged. So the PR interval 0.2 is one big square. So it is more than that, and the normal PR interval is 0.12 to 0.2 seconds. Here the PR interval is 0.32 seconds. So its diagnosis is a first degree AV block. Next is a 86-year-old woman complaining of generalized weakness. What do we find here? We find again a prolongation of P wave. Next, the prolongation has increased. It is more increased, and this is followed by a drop beat. So what is this? This is a second degree AV block, Mobius type 1 or the Vanky-Tax phenomena. But here there are other features as well. I can see an R dash pattern in V1. Therefore, there is associated RBEB, and a criteria for left ventricular hypertrophy has been fulfilled because the AVL is greater than 11 millimeter. So it's a second degree heart block type 1 with left ventricular hypertrophy and RBEB. and see in spite of having an RBEV, this ECG has a left axis deviation because of the left ventricular hypertrophy. Now, the next is the 85-year-old woman presenting after syncopal episode and still reports lightheadedness. What do we see in this ECG? I can see P, QRS, P, no QRS complex here. Here also P, no QRS complex. Here also P, no QRS complex. So there has been non-conductance of the P wave intermittently, and this is followed by a drop beat. And also I can see a LBBB pattern. See, the QRS is prolonged in duration, and there is a M pattern in V5, V6, which I was talking about. So this ECG is a second degree AV block Mobes type 2 with a LBBB. Now, what is the difference between Mobes type 1 and Mobes type 2? Mobes type 2 will also have intermittent non-conductance of P wave, but here in Mobes type 2, the PR interval will be constant in those beats that are conducted, in contrary to Mobes type 1, where there is a gradual prolongation of the P wave, PR interval. Next, this ECG shows a complete AV dissociation. I cannot find any relationship between the P and the QRS complexes, so it's a third degree heart block. So it's AV dissociation. Ventricular rhythm can be either nodal, can be idioventricular, or maybe absent, and this will need a temporary pacemaker. So we come to the pacemakers which are needed in these types of scenarios. So the North American Society of Pacing and the British Pacing Electrophysiology Group have uh, made some code for the identification of the pacemakers, and it relies on 5 letters, and each letter represents something. Letter 1 is the chamber paced, letter 2 is the chamber sense, letter 3 is the mode of response, letter 4 is the programmability of the rate modulation, and letter 5 is the anti-tachycardia function. Now, according to the chamber paced, it can be either none, it can be atria, ventricular dual, similar for the sensing, and mode of response can be none, can be triggered, can be inhibited, or can be dual. Programmability can be none, can be single programmable, can be multi-programmable, can be communicating, can be rate responsive, either to ventilation or movement. And anti-tachycardia function can be none, can be pacing, can be shock, can be dual. So from this knowledge, you can very well understand what type of pacemaker this is, AAO. So here, atrial pacing, atrial sensing, mode of response is none. Here, similarly, the mode of response here, it is inhibited. This is a ventricular pacing VVI mode, and this is a dual chamber pacing, and this is a dual chamber pacemaker with a rate responsive function. So we come to the ECG showing some pacing complexes. You can see pacing complexes before all the QRS complexes. And a very important thing to note is that all the STT waves are discordant to the QRS. So what is the meaning of that? Now, this ECG shows a ventricular pacing with 100% capture, and the STT waves are appropriately discordant. And this is similarly what happens in case of LBEB. And this is very diagnostic of LBEB and also in case of ventricular pacing. Next is 61-year-old man, history of syncope, but now asymptomatic. Why asymptomatic? Because we can see there are 2 pacing spikes here. The initial pacing spike is followed by atrial complex, and then there's another pacing spike which is followed by a QRS complex. So it's AV sequential pacemaker. Again, it's with a 100% capture, because after every pacing there is a complex, an atrial or the ventricular. And again, you find that LBU type of morphology with STT wave discordance. And what is this STT discordance? It means that when the QRS is positive, the STT will be negative. And in leads where the QRS is negative, the STT will be positive. This is one of the indicators of ventricular pacing, and also in cases of left bundle branch block. So how do we minimize the risk of the intraoperative interference from the electrocautery system? So positioning the cautery tool and the current treatment pad so that the current pathway does not pass through or near the pacemaker system. avoiding proximity of the cautery's electrical field to the pulse generator and the leads, using short, intermittent, irregular bursts at the lowest feasible energy level, and using bipolar electrocautery system or ultrasonic harmonic scalpel if possible. Next, we come to the blood supply of the heart, because this is very important, because you will understand when which artery is blocked, which part of myocardium will be affected. So the right coronary supplies the right atrium, the right ventricle, and the inferior wall of the left ventricle. The SA node in 60% case, AV node in 90% case, and also give rise to the PDA in 85% cases, which supplies the posterior interventricular septum. So right coronary occlusion will lead to either RV or inferior wall infarct, and in all these infarct, it is very common to find AV block, because in 90% cases the supply comes through this right coronary artery. Now, with the left coronary artery, it is the two branches of the left anterior descending and left circumflex. The left anterior descending supplies the anterior interventricular septum and the anterior wall, and the SARC supplies the lateral wall. Now, in cases of left dominant circulation, it is only occurs in 15% of cases. The PDA will rise from the SARC. There is a reason of telling this, you'll come to know. Now, the LAD branches are the diagonals and the septals, and the SARC branches are the obtuse marginal and posterolateral. So, how do we localize the leads? The septal is V1, V2, anterior wall is V3, V4, lateral wall is V5, V6, lead 1 and AVL, inferior wall is 2, 3, AVF, posterior wall is V7 to V9, and right ventricle is represented by the right-sided lead V3R to V6R. In a normal ECG, we don't get the V7 to V9 and the right-sided leads. But in a normal ECG, we can still get a reflection of the posterior wall changes as the reciprocal changes in the anterior wall, V1 to V4. Now, when there is a subendocardial injury to the heart, there is always a ST depression. And why this occurs? Because the ST vector is now directed towards the cavity and away from the chest leads. So since it is away, it has to be a negative deflection, and therefore it is a ST depression. On the contrary, when the transmural injury occurs, it is always ST elevation, because now the ST vector will be directed towards the muscle, which is directing towards the leads. So there will be an ST elevation. So what happens when after the injury, infarction occurs, that is the actual muscle necrosis occurs? So the diagnosis will depend on the presence of the Q waves, because why this occurs? Because if the electrical hole is created because of the formation of the scar tissue, and the loss of RF amplitude because of the loss of the muscle or the myocardium. And therefore a transmural infarct will have a QS pattern. But if there is somewhat viable overlying myocardium remaining, it will have a QR pattern. The small r will signify that part of the overlying myocardium which is viable. But all kinds of infarct doesn't have a Q wave, and those are the subendocardial non-Q, non-STEMI infarct, where usually we get a ST depression. So how a STEMI infarct evolution take place? In the hyperacute phase, usually we get a ST elevation with tall T. In evolved phase, we get a Q wave with T inversion. In the stabilized phase, we get the Q wave, and the T inversion is written back to the normal. So already we discussed the blood supply of the heart. You can see the left coronary artery dividing into the LAD and the SARC, and there's a right coronary artery going below as the PDA. Now this is important because at the level of the blockage of the arteries, the zones of the infarct will be obvious to you. See, if the LAD is blocked out here, this part of the myocardium will be gone, and this part of myocardium is the anteroseptal area which it actually supplies. Now, this is the diagonal branch. If only the diagonal branch is blocked, if the infarct occurs in this area, it will have an anterosuperior infarct. And this is the SARC branch with a branch of, this is the posterolateral branch of the left circumflex artery. When this is blocked, it will cause a posterolateral infarct. In all cases of inferior infarct, it is due to the blockage of either the right coronary artery right coronary artery, or the PDA, which in 85% cases will arise from the right coronary artery. But you have to remember, some minority cases, like in 15% cases where the PDA arises from the SAR, and in some cases of congenital variation where the LAD is wrapped around the apex of the heart to supply the inferior wall. In those cases, the inferior infarct can also be due to the affection of the left territory. So, what are the chest leads? For the lateral, it is 1, AVL, and V5, V6. The anteroseptal is V1 to V4, and inferior is 2, 3, and AVL. Now, coming to the ECGs, 46-year-old man with chest and left arm pain, vomiting, and diaphoresis. What we find here is T inversions, 1, 2, 3, AVF, and also in V2, V3, V4, V5, V6, all are T inversions. And this is consistent with T-wave abnormality with inferior and anterolateral ischemia. See, this is inferior and lateral and anterior. So it's a inferior with anterolateral ischemia. And you have to note there are two other things as well. The QT interval is prolonged, and this is because of the myocardial ischemia. And another thing is there is a poor progression of the R wave. How it is defined? Poor progression of the R wave is defined by the R wave amplitude or in V3 less than 3 millimeter. If you see the V3, the R wave amplitude is less than 3 millimeter, and this is one of the definitions of the poor progression of R wave. And what does it suggest? It usually suggests a previous anteroseptal MI, but it may be also be due to left ventricular hypertrophy or abnormally high placement of the precordial chest leads. So, but it is not diagnostic for anteroseptal MI. It is just a suggestion. So you have to rule out other causes as well. Now, next ECG is a 54-year-old woman complaining of midsternal chest pain and lightheadedness. See, there are ST elevation in 1 AVL and V2 to V4 with ST depression in inferior leads. So basically, it's an acute anterior and lateral myocardial infarction. Anterior and 1 AVL, lateral myocardial infarction. And there is a AV junctional rhythm because here the PR interval is also shortened. You see the PR interval is shortened. It is less than 0.12. But the most important finding of this ECG is that there is a reciprocal ST segment depression present in the inferior leads. This presence of the reciprocal change significantly increases the specificity of the ST segment elevation for acute MI, because in many other cases you can get ST segment elevation or depression, but it has to be corroborated by a reciprocal change. When there is a MI, there has to be a reciprocal change in other leads so as to diagnose that the elevation is due to the myocardial infarction. 57-year-old man with chest pain and diaphoresis. What do we find here? See, there is ST elevation in 2, 3 AVF and also in V5, V6. And also there is depression in V1 to V4. These are very interesting ECG because from the ECG, we can see that this is a inferolateral infarct, inferior and V5, V6 lateral. But there are two more possibilities. In this ECG, the ST elevation in lead 3 is much more than in lead 2. And lead 3 is a more right-sided lead that points to a diagnosis of right ventricular infarct. And also, I can see that V1 and V2, where the R wave is usually small, here it is quite big, with there is ST depression from V1 to V4, which is seen as a reciprocal change of the posterior wall in the anterior wall, and this gives a suggestion of a posterior wall myocardial infarction. So see, they have told that the ST segment in lead 3, since it is more pronounced than in lead 2, there can be a coexistent right ventricular infarction. So how do you confirm? You have, in these cases, you have to take a right-sided lead, V3 to V6 right, V3R to V6R you have to take to confirm the diagnosis of a right ventricular infarct. And for the posterior infarct, because there is R waves in V1 to V3 and ST depression from V3 in the anterior leads as a reciprocal change of the posterior wall. So you have to see the V7 to V9 to confirm the diagnosis of a posterior infarct. Now interpreting the heart rhythm. So first you have to see what is the ventricular heart rate. If the heart rate is above 100, it is tachycardia. If it is less than 60, it is bradycardia. You have to see if there are any extrasystoles, atrial or ventricular. Next, as I told you, to see the P waves in lead 2 and V1, and then to find the rate of the P wave, the morphology of the P wave. Is there any 1:1 relation between the P and the QRS? If not, then there is a chance of AV dissociation, and this may be due to a AV block or a ventricular arrhythmia. So you have to see whether every P wave is followed by a QRS or every QRS is preceded by a P, and you have to note the PR interval and you have to see whether it is changing. Now coming to the QRS, if the width is less than 120 milliseconds, it's narrow complex. So the differential diagnosis may be a sinus arrhythmia, supraventricular rhythm, junction rhythm. And if it is more than 120 milliseconds, which is broad complex, it can be ventricular rhythm, it can be supraventricular rhythm with an additional bundle branch block. So what are the differential diagnoses of a narrow complex tachycardia? So if the narrow complex tachycardia is regular, the differential diagnosis is a sinus tachycardia, atrial flutter, paroxysmal supraventricular tachycardia, which may be due to AV nodal reentrant tachycardia or AV reciprocating tachycardia, which needs the accessory pathway, or it can be a simple atrial tachycardia because of a focus in the atrium other than the SA node. Next, if it is irregular, it can be due to atrial fibrillation, it can be due to atrial flutter with variable AV block, or it can be due to the multifocal atrial tachycardia where there are multiple focus in the atria generating ectopic impulse. Now coming to the atrial rates. In sinus tachycardia, the atrial rate will be the same as the ventricular rate because most of the impulse will be conducted, but the heart rate will be less than 200 per minute. In case of PSVT, the atrial rate will be between 150 to 250. In atrial flutter, it will be even higher, 250 to 400. In atrial fibrillation, it will be 400 to 600. And therefore, you can imagine that all the impulses will not be conducted because of the refractoriness of the AV node, and therefore the ventricular rate will be variable. Now, what are the differential diagnoses of broad complex tachycardia? If it is regular, it is monomorphic ventricular tachycardia, or it can be SVT with aberrant conduction. If it is irregular, it is a polymorphic ventricular tachycardia, where there is varying QRS morphology and amplitude, or it may be torsades pointes, where there is a polymorphic ventricular tachycardia with a prolonged QT interval and a twisting QRS complex. So how can we differentiate between a ventricular tachycardia and an SVT with aberrancy? So the points in favor of ventricular tachycardia are absence of the typical RBEV and LBEV and the presence of AV dissociation. I think these are the two most important points which you have to see to rule out whether it is SVT or not. Other points which are less common is that extreme axis deviation, whether QRS is positive in AVR, it actually doesn't happen, or in WAN and AVF, the QRS will be negative. There will be a positive or negative concordance from V1 to V6. That means when you're going from V1 to V6, either it will be entirely positive R or negative QS complexes with no RS transition. There can be fusion beats like sinus and ventricular beat can coincide to produce a hybrid beat. But I think the two important points to remember is that whether you find RBB or LBB, or whether there is presence or absence of a AV dissociation. So the arrhythmias, supraventricular can be atrial or nodal, and then the ventricular arrhythmias. So these are the types of supraventricular arrhythmias, as I discussed: atrial fibrillation, AV nodal reentrant tachycardia, atrial flutter, and all those. So we coming to the next ECG is a 24-year-old pregnant woman with 3 days of frequent vomiting. So what do we find? So it's a narrow complex tachycardia, first thing, and it is regular. And rate is around 150. and I can see the P, Q, R, S, T, everything is normal. There is relationship between 1:1 relationship between the P and QRS. So it is a sinus tachycardia, though the differential diagnosis of a narrow complex regular tachycardia will be sinus tachycardia, SVT, and atrial flutter. But since we find here a 1:1 relationship between the P waves and the QRS, it confirms the diagnosis of the sinus tachycardia. Next is a 61-year-old man with palpitation and lightheadedness. So what do we find? It's a shear shot broad complex tachycardia with a regular rate, and again a rate of around 150. So what do we see? It's a wide complex tachycardia. Differential diagnosis can be sinus tachycardia with aberrant conduction, supraventricular tachycardia with aberrant conduction, or a ventricular tachycardia. So as I told you, first you have to see whether there is any kind of RBV or LBV. So I don't find any features of RBV and LBV here. So, and number two, I can find the presence of AV dissociation. The P waves are intermittently seen in V1 and V2. See, I can see the P wave here, V1 and V2, and also in V2. So these are the P waves, and there is no association between the P and the QRS. So there's a clear-cut case of AV dissociation with absence of LBV or RBV. So this goes in favor of a ventricular tachycardia. So next ECG is 40-year-old man with palpitation and lightheadedness. What do we find here? It's a narrow complex tachycardia which is regular, and I cannot find the P waves. The P waves are either hidden or abnormal, and sometimes I find retrograde P waves here. So it's a narrow complex tachycardia. What are the differential diagnosis? The sinus tachycardia, SVT, and atrial flutter. So you have to see the atrial activity. In this case, there is no 1:1 relationship, so sinus tachycardia is ruled out. I cannot see any atrial flutter waves in the inferior leads, but I can see retrograde P waves, so there is a clear-cut case of supraventricular tachycardia. 81-year-old woman with palpitation and generalized weakness. What do you find here? I can see that all the RR intervals are irregular. So it's a narrow complex tachycardia and irregular. So what will be the differential diagnosis? Narrow complex tachycardia, irregular tachycardia, atrial fibrillation, atrial flutter with a variable AV conduction, and a multifocal atrial tachycardia. So again, we have to go for a close evaluation of the atrial activity. So for the atrial activity, it will be associated with a regular atrial activity, that is the flutter waves. In case of multiple atrial tachycardia, there will be irregular atrial activity with atrial complex of varying morphology. But in this ECG, we do not find any atrial complex at all, so no P waves. So therefore, it is atrial fibrillation. It will not be associated with any notable atrial complex at all. Next is a 63-year-old man with palpitation and lightheadedness. So here it is again a narrow complex tachycardia, but what we find here is the flutter waves are seen in the inferior leads like a sawtooth appearance, and I can see two P waves followed by a QRS. So the P2P rate is around 300, and R2R, this is a ventricular rate, is around 150. So it's a 2:1 heart block. So narrow complex tachycardia, differential diagnosis. Regular is again sinus tachycardia, SVT, and atrial flutter. So here we do find the atrial flutter waves in the inferior leads, and the atrial complex is inverted and manifests as a sawtooth pattern. So this is a case of atrial flutter. Next is a ECG, which is again a narrow complex tachycardia, but now the RR intervals are irregular. So it's an irregular narrow complex tachycardia. So again, what are the differential diagnoses? It will be atrial fibrillation, atrial flutter with variable block, and multifocal atrial tachycardia. But here we do find P waves, so atrial fibrillation is ruled out. Multifocal atrial tachycardia is ruled out because the P waves are morphologically similar and not dissimilar. But the only difference is that here I can find 3 P waves followed by QRS. Here I can find 4 P waves followed by QRS. And here I can find 2 P waves followed by QRS. So all kinds of blocks are prevailing. So it's an atrial flutter with a variable heart block. This is a very classical ECG. You can see the PR interval is shortened. There is slurring of the upstroke of the QRS with a broadened QRS. Though I don't see any tachycardia, but these patients are prone to paroxysmal supraventricular tachycardia, and the diagnosis is straight cut, Wolff-Parkinson-White syndrome with a short PR interval less than 0.2, prolongation of the QRS complex, and a slurred upstroke of the QRS, which is called the delta wave. Now, there are certain morphological difference also between the SVT and the VT in a wide complex tachycardia, which you should also see to differentiate. Because when you see in V1 and V2, in ventricular tachycardia, this R wave will be much broader than in SVT, which is much narrower. In the downslope, there will be a notch or slur in case of ventricular tachycardia. In SVT, the downstroke will be sleek and quick. And in V6, what we find in ventricular tachycardia, this is a normal thing we find, that is the presence of the Q wave. But in SVT, since it is associated with the LBEB, we do not find any Q wave. And again, I find this M pattern, which confirms the diagnosis of LBEB. And therefore, this is SVT with the aberrant conduction. This is another way you can rule out between SVT with the aberrant conduction and a ventricular tachycardia. This is a classical ECG of ventricular fibrillation, totally chaotic rhythm, no P, QRS, nothing is discernible. And this is also a very classical ECG where you find the R on T phenomena going into a polymorphic ventricular tachycardia. Why polymorphic? Because all the QRS is amplitude and the morphologies are different. So this is a polymorphic ventricular tachycardia. So what it needs is a defibrillation. It's a delivery of current to the chest, to the heart, to depressurize the myocardial cell and eliminate the ventricular fibrillation. So what are the indications? Shockable rhythm or ventricular fibrillation and pulseless ventricular tachycardia. If you use a biphasic defib, the initial joule is 120 followed by 150 and 200. For monophasic defib, it is 200, then 300 and then 360. So in biphasic, the current goes to the positive parallel and again reverses and goes back, which increases the success rate to 90%, as compared with monophasic, where the success rate is only 60%. Now, some more interesting ECGs. A 33-year-old obese man with sharp chest pain and dyspnea. So what do we find? First thing, if you see lead 1 and AVF, AVF is predominantly positive and lead 1 is predominantly negative. So it's a right axis deviation. And next is we find T inversion in the inferior and the anterior leads, and also a deep S wave in lead 1 and Q and T inversion and lead 3. All these changes goes to a classical diagnosis of acute pulmonary embolism, where you get the classic S1, Q3, T3 finding, that is a large S wave in lead 1, small Q wave in lead 3, and inverted T in lead 3, associated with anterior inferior ischemia with the rightward axis. So this is acute pulmonary embolism. Next is a 52-year-old post-op scoliosis surgery patient, greater than 6 hours surgery with 2 liters blood loss and hypertensive in the ICU. What is the main finding you get here? See, I can get positive deflection at the terminal end of all the QRSS complexes. And what does that mean? They are the J waves or the Osborn waves, and they are found in cases of hypothermia. The exact cause of the J wave in hypothermic patient is unknown, but they are highly sensitive and specific for hypothermia. With this, you can get an associated prolongation of the QRS and the QT intervals. So here the QRS and the QT intervals are also prolonged. So whenever you get J waves with prolongation of the QRS and QT, always the diagnosis will be hypothermia, but you have to rule out other causes of prolonged QT interval like hypokalemia, hypomagnesemia, hypocalcemia, acute myocardial ischemia, elevated intracranial pressure, and drugs with sodium channel blocking effects like tricyclic antidepressants and congenital prolonged QT syndrome. Next is a 62-year-old man with renal failure and complaints of dyspnea and orthopnea after missing last 2 hemodialysis sessions. What is the obvious finding? It's a tall peak P waves. So this ECG shows not only a tall peak P wave, but I can see there's a prolongation of PR interval and also non-specific interventricular conduction delay, slight broadening of the QRS complexes with tall peak T waves. So peak T waves are the earliest finding in hyperkalemia, and as the potassium will rise, the other ECG abnormalities will develop, including P wave flattening, PR interval, and QRS prolongations, and high degree AV blocks. But you have to differentiate the tall T waves from the other causes. And how do you do that? Like in acute myocardial ischemia or in pericarditis, you can get tall T waves, but here it will be much broader and asymmetric. But for in hyperkalemia, it will be narrow and peaked. So with that, it completes our session. Thank you very much for your patient listening.
Thank you, Gaurav, for a very, very comprehensive review on ECG. I think you couldn't have got a more comprehensive description about the fundamental philosophy, the physiology behind the ECG, the description of a normal ECG, how to interpret an ECG, the various bradyarrhythmias, the tachyarrhythmias, then the ECG changes that happen with certain clinical scenarios, metabolic scenarios. So we'll be good to take questions. I don't see anything that has come in as yet, but this is what I can only tell you is I know it will be difficult for you to remember everything that Gaurav has said. It is like a classic textbook kind of a talk on ECG. But what I would ask you is, if in case you want clarification or anything, you can go back and go through this presentation yet again. It will be available maybe within a day's time or maybe after 48 hours at the HCP forum website, and you can go through this again. You can post your queries or comments over there. Yeah, I would agree with what Shrimantika says over here, that you can't get a more comprehensive and more crystal clear presentation on ECG. And that's why I asked Gaurav to do this.
Thank you.
Gaurav, there is a question. Uh, when do you call a T wave as a tall T wave? What should be the height of the T wave to call it as a tall T wave?
See, usually tall T waves are more than 2 millimeters in the precordial leads, but isolated T waves are less, except for hyperkalemia. They are usually associated with other causes like cases of early repolarization syndrome or in case of left bundle branch block. The main differentiating point with when the tall T are associated with an ST elevation or with the early repolarization syndrome, there what you have to see is that in case of early repolarization syndrome, the T wave will be 4 times than the ST elevation, which will think that it is not basically a myocardial infarction but a early repolarization syndrome. And if you get a specific only T wave abnormality, which you get in case of hyperkalemia, I think it should be more than minimum 2 to 3 millimeter. But usually you don't get. You get associated with a ST elevation, so you have to differentiate between a myocardial infarction and early repolarization syndrome with the balance of the ST and the T, the difference in case of myocardial infarction, the T will be much shorter in relation to the ST, but in case of early repolarization, the T will be 4 times than the ST.
Yeah. I think we can then switch to the next topic that we have in mind. And if I would ask people that if you have any questions, Gaurav will be there till the end of the session. So if you have any questions more on ECG, he will be happy to take it at the end of the talk on cardiac risk evaluation as well. So I will start the evaluation of cardiac risk prior to non-cardiac surgery. Uh, I assume that the slides are visible for you and I'm audible. So essentially what we are going to try and do is evaluation of the cardiac risk for a patient who comes in for non-cardiac surgery. This has been a huge takeoff from the ACC AHA presentation or the publication that came up in which started coming up. The last one that I think appeared is in 2014. We have had few focused updates after that and possibly awaiting a newer one, but till then we'll have to deal with that. Plus there are certain things which are not there in the ACC AHA, which will possibly we will deal with it over here. uh, we all understand that major non-cardiac surgery, there is always a risk of cardiovascular event. And the risk of cardiovascular event is related to the patient. So there are certain patient-specific characteristics, especially those who have a background cardiovascular disease, and also the procedure involved. And identification, which is the essential premise of this next half an hour, 45 minutes. This identification of the risk provides the surgeon, the patient, the anesthesiologist with information that helps them better understand the benefit to risk ratio of that particular procedure, and therefore helps them to take a decision as to whether they would be happy to take that increased risk or there is no risk at all and we can possibly go ahead. And it can also lead to intervention that can possibly decrease the risk. If you look through data, and this is from the American College of Surgeons, the national database on quality improvement program, and they looked at their data from 2004 to 2013. And when they looked at non-cardiac surgery, they're looking at major adverse cardiovascular and cerebrovascular events, that is in hospital, all-cause death, acute MI, or acute ischemic stroke. It is happening in the rate of around 3%. So that's not an insignificant rate. That's pretty significant. And these were happening more commonly in patients undergoing vascular surgery, thoracic surgery, and transplant surgery. So that is why we need to be aware and be careful about this. So what we will go through today is the approach of a patient and looking at the patient, looking at the surgical procedure, how we do the initial evaluation, what are the risk factors, how can we do the risk assessment, and the management based on risk is what flow that we take in. We will not possibly deal with it, and then you will not go to bed by 12 midnight tonight. So we will not discuss about how you can, somebody with a problem, what you do to manage it, but rather the flow through which the patient should go through. And is there any role of doing further cardiac testing? So this is what we will try and go through, a practical approach. Before we start the deliberations, we will have certain poll questions. This is fun. This is to kind of make it interactive. So if you can, Jyoti, if you can get the poll questions ready, we will go through the poll questions.
Yes, sir.
Thank you very much. So all you have to do, this is completely confidential. It is not revealed who is hitting which option. So please feel free to hit it, and we will go back to it, which is essentially the take-home message from the deliberation will be the answers to the poll questions. So the first poll question that comes up is, which of these statement is not true? So one of these is not true, okay? All patients scheduled to undergo non-cardiac surgery should have an assessment of the risk of cardiovascular perioperative cardiac event. The second statement is, patient's functional status is an important determinant of risk. The third statement is, identification of risk factors is derived from the history and physical examination. The fourth statement is, the type of proposed surgery does not influence the risk of perioperative cardiac event. Which of these do you think is not true? So just uh, choose which is not true. A tick mark should appear, and then you can vote. Okay, so if you are, I think this is very straightforward. If you're good, we will close this poll and go to the next poll in 5, 4, 3, 2, 1, 0. So the second poll question is, I think this will be extensively dealt with. Which of the following is again not a part of the revised cardiac risk index? The Lee's cardiac risk index and then the revised cardiac risk index has, as you all know, possibly that there are 6 of them. Which of these 4 is not a part? It is only one of these is correct. So which is not a poll? So can we set up the poll, start the poll? Is it congestive heart failure? Is it cerebrovascular disease, hypertensive on true drugs, or a serum creatinine of greater than 2 milligrams per DL? So one of them is not a part of the revised cardiac risk index. Which do you think is not a part of the revised cardiac risk index? Is it congestive heart failure, cerebrovascular disease, hypertensive on 2 drugs, or a serum creatinine of greater than 2 milligram per DL? Please choose only one option and vote. And we'll close the poll in 05, 04, 03, 02, 01, 0. And we'll go to the next poll question. All right. So the third poll question, this is a kind of your approach. So there is a 68-year-old male with a history of CABG done. Also is a known case of COPD and has developed gallstone pancreatitis and is being posted for laparoscopic cholecystectomy. On assessment, you find that he has a grade of angina, which is CCS3, a grade of dyspnea, which is NYHA3, is the heart rate of 98 per minute. The chest X-ray looks okay. The ECG shows ST changes in the anterolateral leads. The labs are okay. What would be your approach? Cardiologic consultation, coronary angiogram, revascularization, and then take up for cholecystectomy? Or is it just cardiologic consultation, you get a cardiologic clearance, and you go proceed for surgery? Or would it be cardiologic consultation, you optimize the medical management and the symptoms, heart rate control, then proceed for surgery? Or do you think you should send it to the cardiothoracic surgeon post CABG status, redo CABG, a cholecystectomy in the same setting? What would be your preferred approach? 68-year-old, past history of CABG, known case of COPD, gallstone pancreatitis, plan is a laparoscopic cholecystectomy, has CCS3 and YHA3, symptoms, heart rate 98, chest X-ray okay, ECG ST changes in the anterolateral leads, labs are okay. So what would be your preferred approach? Coronary angiogram revascularization and only then take up? Cardiology consult, cardiology clearance, proceed for surgery? Cardiology consult, optimize medical management, heart rate control, proceed for surgery? Or is it cardiothoracic surgery who decides to do a redo CABG and cholecystectomy in the same setting? Choose your option and we'll close the poll in 5, 4, 3, 2, 1, and 0. And we'll go to the next poll question. Okay. So this is a 56-year-old female who is known to have a stenotic mitral valve. The recent echocardiogram shows a mitral valve area of 1.4 square centimeter and has a reasonably good functional status. She is not short of breath and does not impair her day-to-day activity. On ECG, you find that there is atrial fibrillation with a ventricular rate of 106 per minute. She's got a CA ovary which needs surgery. The lab reports are normal. What would be your approach? No further cardiac testing and you proceed for surgery? Or is it a cardiology consultation, heart rate control, and then proceed for surgery? Mitral valve replacement and then CA ovary surgery? Or would it be you just offer radiotherapy and chemotherapy and discourage surgery? So, a known patient with mitral stenosis with a mitral valve orifice area of 1.4 square centimeter with good functional status, no shortness of breath, AF with a ventricular rate of 106, needs surgery for CA ovary. What would be your approach? No further cardiac testing, proceed for surgery, cardiology consultation, heart rate control, and then proceed for surgery? Or is it mitral valve replacement and then proceed for surgery? Or just offer radiotherapy, chemotherapy, and discourage surgery? So if you are decided, please think of which option to take, and we will then close the poll in 5, 4, 3, 2, 1, 0. And we will get back to you with the answers to the poll at the very end. Thank you very much for bearing up with this poll. And now we will proceed towards how we approach towards assessment of cardiovascular risk. See, the two main pillars or columns or whatever you call are the patient and the type of surgery. In the patient, you are looking at the type of the disease, whether it is ischemic or it is pumping or is it valvular or whatever it is, and the severity of the disease, and is there any associated disease along with the cardiovascular disease. And in the type of surgery, the two important thing is when does the surgery need to happen? The timing of the surgery, is it emergency or can it wait? And is it an elective, low acuity surgeries? Or is it an intermediate acuity, time sensitive surgeries? Or it is the high acuity urgent surgeries? And the invasive nerve surgeries, is it the very surface surgeries or does it involve excessive fluid shift, blood loss, major invasive surgery, major hemodynamic perturbations? So these will influence how we are going to assess the cardiovascular risk. Now, are all patients with some history of cardiovascular disease, somebody who has said that he had chest pain 4 years back, is now on aspirin and some nitrate, is doing well, does his work, somebody who's had 2 stents, maybe one in the LAD, one in the RCA, but is very good, functional, is that person with high risk? So who are these patients who are high risk? You see, these patients who are at high risks are those who just had an MI, quick, maybe in the last couple of months, has unstable angina with medications, without medications, so suboptimal medications possibly, decompensated heart failure, not necessarily somebody who was admitted for heart failure long back, now is fine, decompensated heart failure, high grade arrhythmias, things like what Dr. Gaurav also talked about, the basically MOBIS type 2 or a third degree heart block or AF with a high ventricular rate or some of any of the supraventricular or any of the ventricular arrhythmias. So those are the high-grade arrhythmias we need. If they have, it's a high risk. And hemodynamically important valvular heart disease like aortic stenosis, or possibly even mitral stenosis. These are the patients who are at high risk, and you need to be worried about them, because these group of patients has a very high risks of going in and having a perioperative MI, or possibly in heart failure. They can go into VF, or may have just a primary cardiac arrest, complete heart block, and even a cardiac mortality. So this is why you need to assess, are they in that group, and should I be careful? And therefore they need to be optimally treated. And if you find that they have those kind of things that are there with them, refer it to the specialist for evaluation and manage them before you take up for an elective non-cardiac surgery. I think that is the premise of this entire deliberation. How urgent is the surgery? Extremely important. Emergency surgery, which needs to happen within 6 hours, urgent surgery, which needs to happen within a day, or is it a time sensitive, which can be delayed till 1 to 6 weeks, the so-called high acuity surgeries or intermediate acuity surgeries, and elective, which can be delayed up to 1 year, very, very few to far between, like other than the arthroplasties and maybe certain reconstructive plastic surgeries, which can delay up to 1 year. So essentially, again, depending upon the type of surgery, do you have how much of time do you have to optimize and assess is dependent upon this subset, which is the surgery that needs to happen. So patients undergoing emergency or urgent surgery are at a much increased risk of perioperative cardiovascular event at any level of a baseline risk. And you cannot just corroborate risk indexes which are and the elective surgery cohorts, and they will never be accurate to tell you what would be the risk in emergency or urgent surgery. It will realize it goes up to 2, 4 times, 5 times the risk that you would expect in elective surgery. Because you would not have sufficient time for an extensive evaluation of the severity of the patient's cardiovascular problem, and if you cannot assess the severity, you will not be able to optimize. And you are definitely, it is because of the urgency of surgery, because the benefit of going in for surgery is far, far more than optimization, which is why you cannot do additional testing, and you will have to accept that risk and go ahead. Or thing is, you'll have to realize that whatever you are doing in the preoperative, intraoperative period, you have to keep carrying on into the postoperative period. Understand that there might be possible cardiovascular complications, and you need to be aware and possibly manage it in a setting where you can manage such things. So coming now to the initial preoperative evaluation for the risk of a cardiovascular complication. When does this happen? Who does it? And how much should a cardiologist be involved in this? The answer to these are that it happens from the time it is decided that a non-cardiac surgery will need to be considered. Who does it? It starts with the primary care clinician. So it can be this, if it was with the person's GP, maybe that, or maybe the surgeon, and you have to be lucky to get a surgeon who understands that as well. And or it could be, it can start from the pre-anesthesia clinic as well. A cardiologist will definitely be involved, especially if there is an elevated cardiovascular risk and you possibly think it needs further evaluation, maybe also optimization and maybe some kind of intervention before the person goes in for a non-cardiac surgery. So what inquiries are done in the initial preoperative evaluation? It's basically you try to find out the symptoms and the past history. The current symptoms, are there any current symptoms which suggest angina, dyspnea? Is there any symptoms suggestive or complaint suggestive of syncope, or does the patient have palpitations? These 4 are something which should immediately get you going and say that this person needs more attention. From the history, there are certain things that you want to find out. Does the person have history of ischemic heart disease? What have been the interventions? Has the person undergone revascularization? What kind of anti-anginal or other cardiac medications the patient has been? Does the patient have valvular disorder? Is there anything that, along with the valvular, what is happening to the chambers of the heart? What are kind of medications are the patient is on? Is the on rate control or medications to reduce thromboembolic events? All these things you need to elicit over here. Does the patient have associated hypertension, diabetes, chronic kidney disease, or cerebrovascular or a peripheral arterial disease? So these are the things that you need to find out in the initial inquiry. In the examination, you find out the blood pressure, the auscultation of the heart and lungs, abdominal palpation, examination of the extremities for edema and vascular integrity. Things that are worrying and which should be looked for carefully are evidence of heart failure, and can you pick up any murmur which can be which is suspicious of an hemodynamically significant valvular heart disease. So these are the things that you need to look for in the examination in the early on. A lot of the initial preoperative evaluation rests on finding out what is the patient's functional status. How is he doing with the disease that he has? How is he coping with the disease? And this is expressed in form of metabolic equivalents. And a metabolic equivalent is nothing but 1 MET is 3.5 ml oxygen uptake per kg per minute, which is nothing but the resting oxygen uptake in a sitting position. And if you find that the person's, through your questions, if you find that the person has a score of 4 METs and above activity, then you are kind of okay that this is a good prognostic indicator and the patient should not do very badly with non-cardiac surgery. How do you find out the METs? This is a very subjective way of doing it. 1 MET is like taking care of self, looking like that person can eat, dress, and use the toilet is 1 MET. If the person can climb a flight of stairs or walk uphill with a slope at a reasonable pace, then you say that if this kind of activities are done, then you per se that the person has a MET score of around 4. If he can do a little more strenuous physical activity, you say like scrubbing floors, etc., lifting furnitures. And I think during this last 3 or 4 months of lockdown, if you have been managing your own house pretty well and if it's neat and clean, you can be sure that you have a MET score between 4 and 10. And somebody who can take part in strenuous sports like swimming, tennis, single tennis, football has a MET score of 10 and above. So this is a subjective way of finding out the functional status. I think we're very happy from the time, at least I was very happy looking at MET scores from maybe 2004-5 onwards till 2018. And then the question now comes, is MET score a very reliable tool for functional assessment? And this is because of this METS 2018 study, which was published in Lancet. And this is from the Vijay Sundara group, and this is a multi-centric, multinational trial from Australia, New Zealand, Canada, US, and some countries in Europe. And they were trying to look at preoperative subjective assessments with these MET scores and the alternative markers of fitness, like the extensive cardiopulmonary exercise testing. They brought in the basis on which the MET scores were developed, which is the Duke Activity Status Index questionnaire, the DASI questionnaire. And they were also looking at serum NT and pro-BNP concentrations. And the primary outcomes they were looking at, can these predict death or complications after major elective non-cardiac surgery? They found that major non-cardiac surgery and with at least one or more risk factors. And what did they find? They found that when you're looking at MET scores, it had just 19.2% sensitivity. though it had a reasonably good specificity. And this sensitivity was to like when you are actually from after the person is doing a CPET study at the entire at the lab, to actually figure out that what is 4 METs and what we think, and we were giving them the 4 MET scores, that it had just a 19.2% sensitivity. And therefore, it had very poor association with predicting the primary outcome, which is major adverse event for a major non-cardiac surgery. However, the DASI scores were associated with a much higher sensitivity in predicting the primary outcome. And you can see that it is with the CI of 0.83, so it is between less than 1. And they found that if there was a DASI score of less than 34, then these patients were definitely associated with the increased risk of 30-day death, MI, and moderate to severe complications. What was very surprising from the METS 2018 study was that from the elaborate CPET study, where they looked into peak oxygen consumption and anaerobic threshold, these were not associated with moderate to severe complications, and they could not be predictive of the primary outcome as well. So the interpretation from the METS 2018 study, that is the authors as well as to me, is that a subjective assessment like functional capacity with just assigning MET scores is possibly not as good for preoperative risk evaluation. And maybe we think of going back to the Duke Activity Status Index for cardiac risk assessment. So this METS 2018 made me revisit this chart and kind of tell me that this is the one, and I need to take a little more time in figuring out their preoperative cardiac risk. And it is essentially, again, their own physical status, like can you take care of yourself, like that one that we assign 1 MET, you give a score of 2.75, walk a block on level ground, you give 2.75, you can climb a flight of stairs, you give a higher score like 5.5, and if you can run a short distance, you give a higher score of 8. And based upon this, if you get a total score, cumulative score of above 34, then you say that this person possibly has a much higher chance of doing well. So that 4 METs possibly needs to be replaced with this more elaborate but possibly more accurate DASI scores. So maybe it looks for a call in how we evaluate patients in the preoperative. Maybe the next ACC AHA guideline could change based on this. So what models are used for risk assessment? I think the most popular one is definitely the one that was initially given by Lee and still goes by the name of Lee's Revised Cardiac Risk Index. There is, of course, this Gupta myocardial, and the reason I like it is because it has part of my name in it. And or maybe many people in North America are falling onto this, which is the American College of Surgeons, the NSQIP calculator, the National Surgical Quality Improvement Plan calculator. And all these models incorporate certain factors. If you look at it, whatever is there in the RCRI are all there also in the NSQIP. Like the surgery specific risk index. So what is the kind of surgery? Is it major vascular surgery, or is it major invasive cavity surgeries? Does the patient have ischemic heart disease? Does the patient have heart failure? Does the patient have history of cerebrovascular disease? Does the patient have an associated diabetes mellitus, which is insulin dependent? Does the patient have renal dysfunction with a serum creatinine of greater than 2? These are classic RCRIs. And in the NSQIP, you'll find that there is things like increased age, the ASAPS, and also preoperative functional status. And they are trying to incorporate the DASI score. To these, I think I feel, and many others also feel, there is, I think, a huge amount of evidence coming up on this, that along with this, I think there are two things people have left out, which are extremely important in saying that if they have this, there is a higher risk of a post-operative adverse cardiovascular event, which is atrial fibrillation and obesity. Uh, as we were talking, surgery involves risks. So there are certain surgeries which are called the high-risk procedures, where the incidence of a major adverse cardiac event can be more than 5%. There are intermediate group, which is between 1 and 5. And we say there are certain low-risk procedures where the incidence is going to be less than 1%. And it can change based upon institutions who have got expertise in dealing with a particular scenario, or the surgeon. And emergency surgery, we talked about this initially, can have a much, much, much higher risk of 2 to 5 times than with elective procedures. And if you look at it, this is a very elegant study and publication which was done in 2018 by Liu. And what they did was, they took a patient, like a 67-year-old female with hypertension and diabetes, which required oral therapy, obese, who is functionally independent, does not smoke, and is an ASA physical status 2. And what is the cardiovascular risk if the person undergoes these kind of surgeries? If it's a busy slide, it may not be that easily, but what they were trying to see, that things like partial mastectomy, arthroscopic rotator cuff had a much estimated lower cardiac risk than, suppose, a more invasive things like a Whipple's procedure, pylorus sparing, which has a much higher kind of risk, like an odds ratio of 4.7. This actually gave us an idea also, which many people kept on talking, but there was not hardcore evidence, that laparoscopic surgeries are now, people are realizing, possibly has lesser risks of a cardiac complication or cardiac risk when you're looking at a composite 30-day data than open surgeries. Like a lap chole will have a lesser odds ratio than an open cholecystectomy. A lap ventral hernia possibly will have a lesser odds ratio than an open ventral hernia. But essentially, this is to show that kind of with the same given patient factor, how much the surgical factor influences the perioperative risk. And this is something that was there in the previous 2007 and in the 2009 ACC/AHA guidelines. I still like it much better than just two classifications of MACE less than 1% and greater than 1%. It kind of tells me that something like an aortic surgery, or surgery on the aorta, or a major vascular surgery, or even a peripheral arterial surgery has a higher risk than orthopedic surgery, or even an invasive surgery like an intraperitoneal or intrathoracic surgery. And superficial surgeries are the ones which has a MACE risk of less than 1%. So this is surgery and how it influences risks. So the adverse perioperative risk, and all this is because it is giving you in percentage some numbers, some objectivity, and you're getting it from the history, physical examination, some investigation, and the type of surgery. It helps you to, again, convince yourself, convince the surgeon, convince the cardiologist, convince the patient relatives as to then the decision making. Should we proceed for surgery, or should we not proceed for surgery without correcting the problem, or should we give them some alternative? At the same time, this risk assessment might uncover undiagnosed problems or suboptimally treated prior conditions that need attention. And these risk calculators will just look at the Lee's revised cardiac risk index. The 6 factors in that, I'm coming back on this: the type of surgery, history of ischemic heart disease, history of heart failure, history of cerebrovascular disease, diabetes requiring insulin. I have a little bit of an issue on this. I think it should just be diabetes. And renal dysfunction characterized by a creatinine greater than 2. And ischemic heart disease has been defined, and they say it's a history of MI or a positive exercise test, person complaining of chest pain, which is definitely of myocardial origin, use of a nitrate therapy, evidence of pathological Q waves on ECG, and just a revascularization in the past without these symptoms does not categorize them with history of ischemic heart disease. They had ischemic heart disease, which has been taken care of. So that is something that you need to keep in mind. And Lee himself looked at it, and that is from where we got this idea that somebody with two or more risk factor has a higher risk. If you look at it, no risk factor, the risk is similar to what would be an ASAPS2. One risk factor, there is some amount of it. Two risk factors, it goes up significantly, and more than two, three or more risk factors, it is even higher. And this was again shown by a study which was later on done by Devereaux. Similar thing, two or risk factors and three or more, the risk is much, much higher. And this was looked at in 2013, and this gives you a comprehensive, and makes you understand that why we are bothered in that reverse cardiac risk index, that if a person has two, it is worrying. If it is three or more, it is indeed very, very worrying. So, and that gives you an idea and helps you in decision making. And this is across most surgeries, orthopedic surgeries, abdominal surgeries, thoracic surgeries, other vascular surgeries. And the only place that it has not worked in is in persons undergoing major vascular surgery like an abdominal aortic aneurysm. And if you want to look at risk assessment, then you have to look at the VSGNE or the VQI cardiac risk index, which is specifically for vascular surgeries. It essentially has nearly everything. They have added increased age, smoking, abnormal stress, long-term beta blocker therapy, COPDs, along with whatever was also there in the RCRI. So if you are looking at risk indices for vascular, these are the indices to go to. This is something which is, I think, it might be helpful if you can use it. Just visit the American College of Surgery's NSQIP data, the website, and then you will get to a page like this where you choose what procedure that the person is undergoing. Then the patient characteristics like age, functional status, whether it is an emergency, what is the ASA physical status, what kind of is it a clean wound or a dirty wound? Has the person been on medications like steroid? Does the patient have sepsis? Is the patient coming with a ventilator on? What is the BMI? Is he a smoker? And then you kind of create outcome, and it gives you individually whether the person can have a serious complication or a pneumonia, surgical site infection, thromboembolism, renal failure, and a composite kind of a risk, and tell you that whether the person is in the expected risk for that particular procedure or the risk is more. Again, it gives you objective numbers, and it can help you in decision making. So that is about NSQIP. And the take home is, or decision making is, the patients with a low risk, which is less than 1%, from both the patient characteristics as well as the surgery when put together, you possibly do not need any further cardiac testing, and the person can go ahead and undergo the non-cardiac surgery. Those with a higher risk, you'll have to take a call. Should I do a cardiovascular testing? Will that cardiovascular testing change the way I manage the patient and hopefully improve the outcome, not just the surgical outcome, the long-term outcome as well? Or can it help me in possibly in some situation, risk prognostication and stratification as well? So further testing is just not done because there is another test available. It is not done to just lower the risk for the surgical outcome, but it's for the long term. And you would have anyway done this additional testing, whether or not the person was just coming in for a non-cardiac surgery or not. And there are only few circumstances when you can do this for, as I said, risk prognostication and stratification. So from this, the decision making, I think this is, I think one of the most important slides in this presentation is to decide whether I proceed without further cardiovascular testing, or do I postpone the surgery temporarily, do additional testing like a stress testing, LV evaluation, or whatever, and then decide based upon it, do I need to optimize further and then proceed? Or do we take a consensus decision, the cardiologist, the surgeon, you anesthesiologist with the patient relative, that you might be better off by doing a lesser risk possible, or even possibly a non-surgical alternative for that given clinical condition? Or the fourth option could be that this person, yes, needs the surgery, can be done, but before then I need to fix the cardiac problem, whether it is a coronary revascularization or an heart valve replacement, and then go ahead and do the non-cardiac surgery. So this entire, what are the risks, you do the risk assessment, is to come to these possible 4 scenarios that you have to decide on. So again, the management based on risk is whether the patient is at low or high risk, and the surgery, whether it is emergency, and what the timing of surgery. And this is again something that ACC/AHA gave us a little bit, which I have modified for my own liking. You decide first what is the timing of surgery. Then you try to find out whether the patient has an acute coronary syndrome or an active cardiac condition. Then you apply, if it is no, then you apply the risk, one of the risk models, the RCRI or NSQIP, whatever, and figure out whether it is low risk, and then you think of proceeding for surgery. Or is it elevated risk? If it is elevated risk, make this estimation of the functional capacity, previously METs, today possibly DASI. Then think of, shall I do further testing? And if I do further testing, how much is it going to influence my perioperative care? If the answer is no, then if I'm optimized, proceed to surgery with goal-directed medical therapy. And if from your tests, as you said, and that was the fourth part of it, yes, no, I cannot proceed for a non-cardiac surgery without fixing the cardiac problem. The person needs revascularization or replacement, and only then comes in for surgery. So this is the management, and I will take you through this. See, like the patient is scheduled for a surgery with a known risk factor. If it is an emergency surgery, I think the decision making is clear-cut, that the person goes in with clinical risk stratification, hemodynamic goals, and you proceed for surgery. So the decision making is easier. If it is not an emergency surgery, the next question you ask is, does the patient have acute coronary syndrome or an active cardiac condition? Now, if the person has an active cardiac condition, then obviously it will be different. If the person, you find that it's a non-emergency surgery, no active cardiac condition, you apply the risk models, find out the estimated perioperative risk based upon the combined, again, the patient and the surgery. You can have 2 things. It can be either low risk or an elevated risk. If it is low risk, you just proceed to surgery. The person does not need any further testing. Now, the thing can be that the person has an active cardiac condition or acute coronary syndrome. You have to then evaluate. The non-cardiac surgery has to wait, evaluate, treat according to the goal-directed medical therapy, and then apply the risk models, figure out whether it is low risk and then elevated risk. And if it is an elevated risk, as I said, find out the functional status. What is the MET score? This ACC/AHA has been based upon the MET scores. Maybe we need to change it and get to the DASI scores. If it is a MET score which is greater than 4, like able to do high strenuous physical activity, then no further testing. What else would you want to find out? The neuroendocrine stress response, the inflammatory stress response of the non-cardiac surgery, the person can well handle it, and you can proceed for cardiac surgery. If it is poor or unknown, this is when the second decision making comes. Shall I do further testing? Will it impact my decision making of perioperative care? Will it be yes or no? If it is, you decide a no, and we'll come through scenarios where you will figure it out. So it typically happens when you are looking at high acuity cancer surgeries, that you do not have the time for doing things like revascularization or replacement. Then we proceed to surgery with goal directed medical therapy, or then we don't think, no, surgery cannot be a option for this. We have to think about alternative strategies or palliative strategies. If it is going to impact your perioperative care, then you do further testing, things like pharmacological stress testing. And if the pharmacological stress testing is normal, it gives you more confidence, it gives you more strength, and you proceed for surgery, again, with the goal-directed medical therapy or whatever. The pharmacological stress testing proves that it is very, very bad. And then you, again, think about giving alternative strategies. It's an abnormal pharmacological strategies, and then you have decided, no, the non-cardiac surgery cannot happen without fixing the cardiac problem, revascularization or replacement of valves, and then proceed for non-cardiac surgery. And this is the algorithm that has been used. And you heard about further cardiac testing. What is there in further cardiac testing? And we have kept on repeating this, that it can be done only when you would have anyway done with or without the surgery coming into the equation. And this is, again, to find out the burden of the disease, the burden of the valvular disease, and the what is the reason of this arrhythmias which is causing symptoms. That is what the functional further testing is being done. There comes a question, I think this ACC-AHA kind of brought it up, is the 12-lead ECG, should it be for everyone? And the 2014 kind of tells you that yes, cardiovascular disease, anybody undergoing a surgery which is a risk of MACE of greater than 1% should have a baseline ECG. It's only in asymptomatic or with a MACE of less than 1% that you can think of not doing a 12-lead ECG pre-op. Our take is that we would do it in everybody with some history of cardiovascular disease, because that is the one of the baseline that is available if it was not available, and on which to base upon in case there is a post-operative aberration that is happening, to fall back upon whether there has been any change to the baseline ECG. Who needs LV evaluation? I go back again to the ACC-AHA 2014. This is very intuitive. Anybody with a dyspnea of unknown origin should get an LV evaluation. With current or prior heart failure, worsening clinical condition, worsening dyspnea, should get a LV evaluation. And this is what you would have possibly not done without the surgery, that there was a documented LV dysfunction, and some people say if it has not been recorded in the last 6 months, and ACC-AHA says 1 year, that there is a role of getting a echocardiography for LV evaluation done. It should not be, as per the ACC-AHA 2014, be done routinely preoperatively. When to do stress testing? Again, I'll go back to the ACC-AHA classification. Somebody with RCRI 2 or above, risk index, a MET score which is less than 4, undergoing an intermediate or a major cardiac surgery with a MACE score with a MACE of more than 1%, should undergo a non-invasive pharmacological stress testing. And again, as we figured out, if it changes my management, if it is not going to change my management, people say that then it's a waste of time. To change of management, what I can possibly say, many people use it to further risk prognosticate and risk stratify. What has come in to other than this this kind of testing is the role of preoperative beta natriuretic peptide testing, and has been used in conjunction with the risk models, and it gives you an objective number. Anything above a number of 400 In a dyspneic patient, it is definitely possibly due to heart failure. A risk score of less than 100 has a very high negative predictive value for that heart failure is not the cause of dyspnea. You have to look for other causes of dyspnea. NT-proBNP in normal subjects, both are nearly the same. If LV dysfunction, the NT-proBNP are approximately fourfold higher than the BNP, and NT-proBNP below 300 is just like that was for 100 is optimal for excluding a diagnosis of heart failure. So heart failure is something that should be bothering you. And if there is a person with a decompensated heart failure, all non-cardiac surgery has to stop. It has to be optimized before you take that person in for surgery. And this is even for an urgent non-cardiac surgery with 3 arms, stable, a patient with a new onset or acute decompensated heart failure, or a person with refractory heart failure. What do you do with it? If it is a stable heart failure, then somebody who has a MACE of 1%, less than 1%, you can possibly go ahead with surgery. Not decompensated, not refractory heart failure, stable heart failure. If it is new onset or acutely decompensated, and urgent surgery means you have around 6 to 24 hours. Try to stabilize that in the next 6 to 24 hours. If they can be stabilized, and if a MACE is less than 1%, then you can possibly proceed for surgery. If you cannot stabilize, then you continue therapy, and you'll have to really think, should this patient go ahead for a non-cardiac surgery? The same is about refractory heart failure. You continue therapy and you reassess and think, is there going to be a benefit from the surgery? Does the patient have other options, palliative options, and think about a non-surgical therapy? So non-stabilized, decompensated heart failure, refractory heart failure, think very hard before you take these patients up for even an urgent non-cardiac surgery. Heart failure with non-elective non-cardiac surgery, again, if it is stable, MACE less than 1%, you possibly don't even have to do further cardiac testing. Go ahead with a non-cardiac surgery. New onset heart failure, waiting for elective surgery where you can wait for a month, maybe 6 weeks or so, you have to try and stabilize that, and then look at the functional assessment, and then decide what is the risk-benefit analysis. The take-home is new onset heart failure, treat it for at least a couple of months or 3 months, and then decide for an elective non-cardiac surgery. If it is acutely decompensated heart failure, again, that was 3 months, at least try to treat it for a month before an elective non-cardiac surgery. And unless they are refractory, or if they get refractory, again, it is the same thing. You have to think very hard before you take this person up for an elective non-cardiac surgery. Think about other options. Murmurs, we'll quickly run through this. It could be undiagnosed systolic murmurs or diastolic murmurs, which is very, very common. A systolic murmur with a symptom of dyspnea, chest pain, history of syncope, and an ECG abnormality. Look at the heart and get an expert evaluation before you take this person up. Any diastolic murmur is pathological and warrants further evaluation, because things like mitral stenosis has definite impact on poor perioperative outcome. Valvular heart disease, stenotic lesions are much, much more difficult to deal, and you will have to figure out how you are going to manage these patients in the intraoperative period. Invasive monitoring, which goes into the post-operative period, and you have to look at proper institutions where you can actually do it. Like aortic stenosis, the severity of the disease, again, it can be asymptomatic with a severe disease. Anybody with a gradient of more than 60 with an orifice area less than 1 centimeter, or they can be asymptomatic severe AS with a low ejection fraction of less than 50%, or they can be symptomatic severe aortic stenosis. Along with that, if they have certain other, like a coronary artery disease, the risk becomes much, much more, and you will have to really think hard before you think of taking these patients if they are symptomatic for a non-cardiac surgery. If they're not symptomatic and you think that this person will benefit from the non-cardiac surgery, then appropriate monitoring into the post-operative period, asymptomatic severe AS may be taken up. Asymptomatic AS without another valvular disorder and a significant coronary artery disease may be taken up with an increased risks for a non-cardiac procedure. If it is symptomatic, non-cardiac surgery, elective non-cardiac surgery should wait, and the person's valves needs to be taken care of. So whether it would do a surgical AVR or a transcathetic AVR, balloon mitral valvuloplasty, not much popular, but that needs to be fixed before you take up. About mitral stenosis, again, the operating word is not just the severity of the disease based upon the valve anatomy or valve hemodynamics, just like aortic stenosis, just like a mitral valve orifice area of less than 1.5 centimeter with a PA pressure which is more than 30 would keep still asymptomatic but severe, versus a person who has decreased exercise tolerance and exertional dyspnea. The ball game is completely different. Asymptomatic, without pulmonary hypertension and atrial fibrillation, possibly many people say there is no excessive risk as long as you do and follow the hemodynamic goals, which is heart rate control, blood volume control, and vascular resistance control. And there is a group which is coming in who says that even in severe MS, but who are asymptomatic with a favorable valve anatomy, to be taken up for a moderate to high risk non-cardiac surgery, there is possibility of role of preoperative percutaneous balloon mitral valvotomy. Unfavorable anatomy, asymptomatic severe AS, it may be reasonable to proceed with a moderate risk, again with the same hemodynamic goals. But again, the same thing as was with aortic stenosis. If it is symptomatic, I think the valve needs to be addressed. Regurgitant valves, AR, MR, typically tolerated better than the stenotic lesions. Again, let's look at what are the predictors for increased cardiovascular risk in patients with a moderate to severe MR or chronic AR. It's LV function, associated fibrillation, or an ischemic MR along with it, and comorbidities like diabetes, carotid endarterectomy. To chronic AR, it is again the same thing, plus renal dysfunction and lack of perioperative management. Valve surgery prior to non-cardiac, when do these regurgitation lesions need to be taken care of? Again, it is if they are symptomatic, and even with preserved LV function, if they're symptomatic, they need to be taken care of. If it is asymptomatic but with diminished LV function or a high LV dimension for an MR or an AR, which is again symptomatic or asymptomatic with depressed ejection fraction, or if you see that there is a bicuspid aortic valve, then they might need to be intervened. The problem with valve surgery prior to non-cardiac surgery is that it may not always be visible, especially when you're looking at time-sensitive surgeries. And then the factor of anticoagulation that also comes in it. Some patients require an urgent procedure, and the risk of the valve and surgery itself may not be acceptable for many, and they therefore decline it. So when is it reasonable to proceed? I think the operating thing is symptoms. Symptomatic severe MRAR, urgent non-cardiac surgery, you have to really take a hard call and then decide whether you go in or not. Mechanical heart valves, it's the role of when to interrupt coagulation, how much is the bleeding risk, should I stop, how much is the thromboembolic risk, should I continue? I think that is a conundrum which needs to be addressed in its own. Arrhythmias, are all arrhythmias bad? The role of just a supraventricular tachycardia, asymptomatic, even an asymptomatic ventricular arrhythmia, how much you need to intervene is still not known. A symptomatic bradycardia, obese type 2, complete heart blocks definitely needs intervention prior to a non-cardiac surgery. If the commonest arrhythmias possibly that you would encounter, clinically stable patients with AF, thing is, if you go by recommendations without a rapid ventricular rate, you possibly, and just by modification of anticoagulation, you might proceed for a non-cardiac surgery. But if that has been recently found out or a recently diagnosed, it has to be evaluated before you take this person off for non-cardiac surgeries. I'll just close with certain case scenarios to just take you through the management algorithm. I know we are getting late. So this was what we decided, that the stepwise algorithm. Let's put in a case scenario. Let's say a 56-year-old with pain abdomen, tenderness, rigidity, septic, in metabolic acidosis, has a twisted ovarian cyst, complaints of chest pain even at rest, breathless on day-to-day work, ischemic heart disease, hypertensive, diabetes, tachycardic, BP is okay, on nitrates, aspirin, atenolol, diuretics, insulin, anterolateral ischemia, bilateral pleural effusion. So what do you do? Now, twisted ovarian cyst is the operating word. So what is the type of surgery, timing of surgery? This is an emergency surgery. So for an emergency surgery, the rest of the algorithm does not come into question. You straight away proceed for surgery with goal-directed medical therapy. Now, suppose I tweak it and say that this same lady does not have a twisted ovarian cyst, is diagnosed with an ovarian cyst, same chest pain at rest, breathless on day-to-day work, same parameters. Now apply the algorithm. What is the timing of surgery? It is a time-sensitive or an elective surgery. Does the patient have an acute coronary syndrome or an active cardiac condition? Yes, the person has. Then you apply the risk assessment models, stabilize the active cardiac condition, and figure out whether there is an elevated risk, try to find out the functional capacity, and then decide on what you want to do. Whether you need to do further testing, will further testing help, and then take up. But without stabilizing the medical presentation of dyspnea at rest, chest pain at rest, a non-cardiac surgery will need to wait. 46-year-old bleeding PV, the plan is a hysteroscopy, angina on severe exertion, not breathless with regular activity, diabetic, hypertensive, good heart rate control, good blood pressure control. What do you do next? Let's apply the algorithm again. The surgery is time sensitive. The person does not have an acute coronary syndrome. You apply the risk model. It's a hysteroscopy, not very invasive. Low risk. Shall I proceed for surgery? In this person, do you think you should do further testing? I think you just apply the goal-directed medical therapy and go ahead with the surgery. Fibroid uterus needing a hysterectomy, angina, breathless occasionally, ischemic heart disease, on medication. The only thing is she also has osteoarthritis of the knee, unable to walk, climb stairs, and is a little tachycardic. What next? Apply this algorithm. No, she does not have ACS. Apply the model. This is an invasive surgery. Functional capacity is you cannot determine because of the osteoarthritis of the knee. Then comes the question, should I do further testing? That again has to be decided by a consensus opinion between the cardiologist, the surgeon, yourself, the patient and relative, that do I do pharmacological stress testing just for risk prognostication? Or if the pharmacological stress testing shows something that is wrong, should I fix it and then take up the person for surgery? Again, very, very individualized. So that is about it. And with that, we will wind up with the answers to the poll questions. I could figure out that I think most of you got most of it absolutely correct. And this is very, very simple. Which of it is not true? Of course, the type of surgery does influence the risk of perioperative cardiac outcome. I think more than 70% people voted for this. And which is not a part of the revised cardiac risk index. I think if people have got so used to this, it is absolutely simple. Hypertension does not figure in it. So it is the type of surgery: congestive heart failure, cerebrovascular disease, insulin on diabetes, and a creatinine of greater than 2 milligram per DL. Okay. I think this also, many people would have done what I would have thought I would do. CABG, COPD, gallstone pancreatitis. I think these are the things that need to be fixed. The CCS of 4, the NIH of 3, the heart rate of 98. Send it, of course, get a cardiology consultation. Optimize the medical management if you can get them down to around 2, a heart rate around 70, less than 80, and then decide to proceed for surgery. So this is possibly what most of you also would have done, I figured out. And stenotic valve, severely stenotic valve, less than 1.5 centimeter, but asymptomatic, no shortness of breath, no functional deterioration, but has a needs surgery for CA ovary. What should be your approach? I think most of you got this again right, is heart rate control and then proceed for surgery. Thank you very much. And I think we will take up questions now. Gaurav, is there something that you had to answer before I can see? Dr. Kusuma Parekh has a question. Patient with CA bladder with hematuria with a history of chest pain 15 days back. Angiography showing triple vessel block, was advised CABG. Should we go ahead? You should run away from that patient. CA bladder with hematuria, you need to actually take a call on this, because you need some kind of intervention, because whatever, if you do, whether you do whatever revascularization, whether it is CABG or you do a percutaneous revascularization, you will definitely give antiplatelets, and the bleeding from the CA bladder will possibly worsen. At the same time, if you do not address the triple vessel coronary artery disease, and especially with somebody who has documented chest pain, has a chance of having an adverse perioperative event. I think you have to, the urologist, yourself, the patient, and the patient relative needs to sit down. Is there any other way that you can possibly manage the bleeding? Is there any other lesser intervention kind of a modality to address that? Is I think something that you can think of. And otherwise, I think it could be medical management. If you've got the goal directed medical therapy, again, heart rate control, blood pressure control, symptom control, take away the bleeding from the patient's pathophysiology, and then possibly think of a long-term solution to the triple vessel coronary artery disease. That would be how I would look at. Professor Amna Goswami, thank you, ma'am, for being with us. She had a question: is prolonged beta blocker therapy looked upon as a risk factor? Many of us are there for now. I don't think prolonged beta blocker therapy is to be looked down upon as a risk factor. I think the vascular surgery group said that prolonged beta blocker is a risk if they are undergoing major vascular surgeries. Other than that, the only thing is, if you have been on prolonged beta blocker therapy, you need to continue beta blocker therapy into the perioperative period. Manoj Ghose question: how much is the resting echo helpful? How do we? What do we need to know beyond the ejection fraction? I think ejection fraction is the first thing that you look at, but there are other things that you need to look at from the resting echocardiography. I would be looking at the diastolic dysfunction, because the diastolic dysfunction, especially grade 2 and above, especially 3 and above, have been known to cause significant hemodynamic problems in the perioperative period. So I would be looking at diastolic dysfunction. I would be looking at definitely the wall motion activity, the valves, and the surrounding of the chambers, the pericardium. So those are the things that the information that I would try to find out from the resting echocardiography. Plus, is there anything that I can understand from the pulmonary arterial pressures? That is from the resting echocardiography, and essentially the stress testing is nothing like the dobutamine stress testing. You're just stressing the heart, and to find out that when you're subjecting the patient to a physiological stress, how much the heart copes with it. I think that is all that you try to find out from the LV function. Dr. Raghu has a question as to how to assess functional reserve in geriatric patients posted intermediate risk surgery. If you go by the MET scores, most of them would have a score of less than 4. If you go by the DAS, you'll get them to have a score of less than 2. So then you obviously there and plus age is an independent risk factor for adverse perioperative outcomes. So really, what else would you try to do if you are trying to do a 6-minute walk test to find out the cardiopulmonary exercise reserve? It will be extremely difficult, and they will fare very poorly on that as well. So I really don't know what else do you want, what can find out. Again, a stress echocardiography, just for the sake of risk prognostication and stratification, you might do it to tell you whether any wall is showing wall motion changes, or even if you want to do a thallium scan to pick up areas where their perfusion is less. But then again, for a geriatric, would that person or the person relative or possibly even the surgeon be willing to fix that problem and then take up for the non-cardiac surgery? So I don't think you will have just a simple one-off answer to this. I think that's it from my end. We will close, and again, I would request that you will get a email from the HCP Forum and Kolkata Anesthesia Academy. Would be very, very happy to uh, know what you felt about this, what topics you think you can needs to be addressed in the future, how we can get better, how we can look better. Not necessarily our slides, how can our mugshots look better as well. And thank you, Gaurav. And I would ask Dr. Jayati to make the concluding comments. Thank you, everybody.
Thank you, Dr. Saikat and Dr. Gaurav, for the wonderful presentation. And thank you for the audience, for a lovely audience, and thank you for all the queries. We'll like to have you in future also for our future webinars, and you will get a mail from us for the feedback and the certification thing. So please reply to the feedback and you will get the certificate accordingly. Thank you. Thank you, everybody.
Anyway, thank you, HCP Forum, for being taking care of the back end. And it's good to see that a lot of our friends from even across the border, I can see Dr. Lutful Aziz thanking us. Thank you, Lutful, for being there. We had Dr. Chakrara, who was there. We had Dr. Kanchi Muralidhar, who was with us. Thank you. And we had Dr. Amna Goswami, who is always with us. And a lot of senior people and a lot of our students, some of them I can recognize, some of them I cannot. Thank you for being there. We'll try and come up with something again next Friday or maybe Friday after that. And with that, I think I will sign off and close the session for tonight. Good night. Bye-bye. Take care. Yeah. And happy Eid to all of you. So I don't know what is there in the platter for you at night, but maybe there is something make justice to the day's celebration. Thank you.